I'm so glad you're back home.
Me too.
First hospital I went to, they'd done a CAT scan. But for some reason at the second hospital, they couldn't seem to get a hold of the pictures or the files or whatever they are. So they want me to take another CAT scan, but now at their hospital. So I gotta go through 2 CAT scans?
The nurses would tell us, don't be afraid to ask questions. Now that's all well and good, but I didn't even know what questions to ask. I mean, what do I know about heart attacks?
The best thing would be if they could answer your questions before you even had to ask them.
With congestive heart failure, they give you the water pills, you know. Well, the nurse comes by and asks me if I'm having any problems with them. Yeah, I'm having problems with them. I'm going to the bathroom like every 2 minutes. But I'm not going to tell her that because I'm just not comfortable talking to a woman about these kinds of things.
When my wife had the stroke, I started keeping a journal. So I know this for a fact. In the first 24 hours after the stroke, my wife was seen by 12 different doctors. She still sees 6. And I don't know how much they even talk to each other.
Communication in healthcare can be a challenge, whether it's between providers or with patients and their families. Particularly in transitions in care, communication issues often occur, and it is during care transitions that effective communication is especially critical. Therefore, in this program, we'll be taking a close look at the challenge of effective communications. And please note that a viewer's resource guide containing resources such as sample forms and materials accompanies this program. Now, in order to improve communication during transitions of care, we need to begin by identifying the reasons why breakdowns in communication occur in the first place. And we asked several experts on the topic of care transitions for their opinions. Dr. Eric Coleman, professor of medicine at the University of Colorado, Denver, is the developer of the care transitions intervention.
Whereas before, physicians were called physicians, now, as you know, we have terms such as hospitalist, sniffist, and so forth. What that does is it creates a bit of a culture such that moving or considering other care settings is a bit like traveling to a foreign country. They speak different languages, they use different forms of communication, and that in and of itself becomes a potential barrier.
As care has become more complicated and we've had to turn over our patients to other caregivers, to other settings, because the next patient is coming in, we don't always have time for that clear, thorough communication. Not that healthcare professionals don't want it to happen, but the pace is faster. The amount of information to share is not only more voluminous, but it's more complicated.
We tend to do it at the last moment, right at the time of discharge. There may not be a good process for communicating. We don't have individuals with assigned responsibilities for communicating, whether it's to the patient or to that next provider of care. And without that, often it doesn't get done.
In response to these issues, there are several strategies for improving communication about transitions of care among healthcare providers. To start, organizations should consider routinely including patient discharge information as a part of multidisciplinary rounds.
What some studies have found is that including discussion in multidisciplinary rounds about discharge every day can lead to a safer discharge, lower readmissions. So what does this mean? Well, many hospitals have multidisciplinary rounds. It usually depends on the medical staff being available for the full team, and other people join in and the patient caseload is reviewed and what's happening with the patient is discussed. Why not add 30 seconds to talk about preparation for discharge?
Another technique is to increase understanding among the various healthcare disciplines about what each discipline needs and does.
We've seen some success in what we euphemistically call the Welcome to My World Day. In this context, we've worked with some quality improvement organizations for how care professionals in one setting, in a very brief period of time, can spend a little bit of time with their colleagues in other settings, whether that's going on site for an hour just to find out what their challenges are, but perhaps more importantly to realize that health professionals in other care settings are not necessarily out to make their day difficult, that really there are some very simple cultural differences that can be addressed and agreed upon modes of communication can then be established.
In particular, researchers are now looking at ways for enhancing communication between hospitals and primary care providers as a means to improve transitions of care.
There's a lot of research that supports having a standard communication template with our primary care providers where we're providing not just information about what happened to the patient and what their current status is, but what that primary care provider needs to do for that patient, so that there is a very clear communication of what they need to take on at this point in that patient's care.
A redesigned discharge summary can be another tool for improving communication between hospital-based providers and primary care providers.
It may be time for us to think about reinventing the discharge summary so it becomes a brief, action-oriented document. And in this context, we would recognize that the hospital physician, even though it may be the first time this physician met the patient, they've cared for them in the facility for 2, 3, 4, 5 days. They have a pretty good sense about what kinds of challenges that patient may face in the days after discharge. In fact, they can probably anticipate. So what if this more action-oriented discharge summary had a series of if and then statements where the hospital physician would anticipate a series of possible scenarios and offer relatively simple solutions for what the next physician might consider doing.
While effective communication among staff and physicians is critical, it's just as important to communicate meaningfully with patients and families during transitions of care. Dr. Mark Williams is a professor and chief of the Division of Hospital Medicine at the Northwestern University Feinberg School of Medicine. He also leads an initiative to improve care transitions known as Project Boost. Dr. Williams stresses the need for the concept of teach-back in communicating with patients.
It isn't enough, if you will, to just show information to patients. When we send our kids off to elementary school, we expect them to be tested to make sure they've learned the material. We don't expect the teachers to simply talk at our kids and say, I'm done teaching, Johnny passes with an A because I spoke to him for 5 days.
Can they repeat back the teachings that have been shared during a hospital stay, really demonstrating that they understand? Can they demonstrate the skill that may have been taught? Can they inject insulin? You know, have they shown the nurse who taught them that they know how to do it now?
The worst question a healthcare provider can ask a patient is, do you understand? Because that provides an escape for the patient to say, yes, I understand, when they really don't.
For Dr. Coleman, the use of a straightforward patient-written personal health record is a key method for enhancing communication.
First and foremost, this is not to be a comprehensive record. That's best left to the professionals. In this case, a patient-centered record has really a core set of essential information that that patient would need if they, for example, required emergency care from a professional or a facility that they had never seen them before. So that would include things like a problem list, medication list, allergies, advanced directives, and who their family caregivers are and how you could reach them. Another key lesson we've learned along the way is that if we make these personal records too fancy, some of our patients will choose to leave them at home because they're afraid that they may lose them.
Similarly, Project Boost makes use of a form they call the Discharge Patient Education Tool.
That is a brief summary of what happened to the patient while they're in the hospital and what's their subsequent follow-up. And we make it very patient-centered. So for example, when describing what happened in the hospital, we use patient-centric phrases such as, while I was in the hospital, I was treated with, this was for this condition. While I was in the hospital, I underwent this test. The results of this test were. So this back and forth of what happened and why, so that the patients can understand it. With this type of approach, the patient gets 1 or 2 pages describing what happened in the hospital instead of 25 to 30 pages of education material that's very dense that they're not typically going to read all the way through.
Emerging technologies, such as the electronic health record, represent another avenue for improving communication. But careful consideration should be given to the design of the EHR to increase its usefulness.
If I were to design the most state-of-the-art electronic health record, I would make sure that we included on the face sheet, who is this patient? What is their baseline? All too often this gets lost in the different tabs and the different parts of the electronic health record. We would also include what the patient's baseline level of cognitive function is. I would also like to see on that face page an identification of who that individual's family caregivers are and what roles they play and how to reach them.
True cutting-edge technology is being used for delivering discharge instructions as part of the Project Re-Engineered Discharge Initiative. And according to primary investigator Dr. Brian Jack, her name is Louise.
Louise is an embodied conversational agent, which is an animated computerized character that is not a videotape, but is unique software where Louise can speak from a database. This new technology that we have developed now allows us to push a button and the information goes to a kiosk with a touchscreen on it with an extendable arm that goes over the patient bed. So the patient, prior to discharge, the nurse can wheel the kiosk into the room, put the arm out over the bed, push the button, and Louise, the embodied conversational agent, is now able to teach the after-hospital care plan automatically. She knows the patient's name, she speaks with empathy towards them, she knows about what their specific medications are, their appointments, where those appointments are, who their doctor is, etc. And that she does something that we don't all do enough, which is to test the ability of the patient to understand what they're supposed to do when they go home. So she does teach back. We have data to show that when at the end of the interaction we ask patients, who would you rather receive your discharge information from, a doctor or a nurse or Louise? Twice as many people say Louise than a doctor or a nurse. And the answer is because Louise has more time and explains more carefully about what I'm supposed to do before I go home.
More and more healthcare organizations are improving their communication processes during transitions of care. An example is Health East Care System, headquartered in St. Paul, Minnesota. Health East makes use of Dr. Coleman's Care Transitions intervention. Their leadership feels that better communication begins with listening, both to patients and to staff.
It really is to keep the patient at the center and to hear and understand what our staff are telling us at the bedside and what recommendations they may have for improvement, because they're really the ones who know. And so our role is to listen, to take the information in, understand what their recommendations are, and bust any barriers that may be out there.
Previously, as is the case with many organizations, staff had the tendency to work in silos. Their new model stresses team communication and longitudinal thinking.
When you've got staff that are already overloaded with responsibility and duties, to say you need to think longitudinally, you need to communicate across all systems and really think about that next level of care, that is a very different culture shift.
To enable this shift, Both informal and formal communication about transitions of care is encouraged, with the latter taking place largely through interdisciplinary care rounds.
They're scheduled at a certain time, and depending on the unit of what the care is on the unit depends on who the key members of the team are that are there. So they're going to be talking about the care progression of each patient, and that would of course include discharge.
It's not just the physician prescribing a treatment for the patient that will get the patient out and keep them in the community where they want to be. The physicians need the case manager, the floor nurse, the charge nurse, the pharmacist, all of them to come together.
Beyond staff communication, in talking with patients prior to discharge, Health East strives to make the process as individualized as possible.
There's some patients that English isn't their first language, and we have interpreters available. And sometimes it's that the patient is just more vulnerable and is more compromised at this point in time related to their illness. And we do encourage at that time for them to have someone with them.
Another key is to talk to patients, especially those with more serious or chronic conditions, about services and programs that can help them manage their health.
We coach them to talk with their doctors about cardiac rehab, about getting into the congestive heart failure program. We work with parish nurses, nurses in the community that can help people get the help that they need at home. If they can't cut the grass anymore, if they can't go downstairs and do the laundry, parish nurses can sometimes help them get hooked up with volunteers.
Lastly, the organization tracks a multitude of patient-related data points.
We've been able to reduce readmissions to the hospital. The patients are more knowledgeable about their medications. They know when to call their physician, the signs and symptoms that they're having that could potentially get them into trouble, and really connecting them with primary care, because that's the center of where their care is being delivered in the community, have all been success stories for us.
Effective communication during transitions of care is also of great importance at Piedmont Hospital in Atlanta, Georgia. Piedmont is a Project Boost site. The method with which the hospital has staffed their units has proved to be a boon to communication.
It was decided very early on that we were going to create what we call a geographical hospitalist ward, which meant that it would be one nursing station with one physician, one case manager, one IMS nurse, and that would make the core team who would then work with the floor nursing, physical occupational therapy, and respiratory therapy. That in and of itself facilitates communication in ways that you can't imagine.
We've developed relationships with each of our home health providers. We now write their orders for them on discharge so that they know exactly what's wrong with the patient, how to execute their care. And we've gone out on a limb and said that we will provide supportive care for them for 30 days up until or when they are attached back to their primary care provider.
Both high-tech and low-tech tools help enable communication about care transitions. For example, each unit has an old-fashioned dry erase board known as Command Central. Every key aspect of each patient's care is noted on the board, including any barriers to discharge. At any given time, a physician or staff member on the unit can look at the board and find out immediately what's going on with their patients.
It's updated every day so that as patients transition from the ICU setting to the floor setting, from floor to home, that board is updated with whatever pertinent information is needed at any given time.
On the other hand, the staff also has access to the primary care provider's electronic medical records for their patients.
So we can go in and look at how the patient's visit history has been with their primary care provider. Have they shown up for their visits? Are they compliant with their medications? What medications were they taking that the doctor's office has note of, so we can match that to what we have the patient on, and then in return, when we make a post-hospitalization follow-up phone call within 72 hours of discharge, we document that into the same electronic medical record so the doctor's office can actually visualize and see what we did for the patient and how the patient's doing at home even before the patient gets to their office.
The communication process among staff and physicians is also streamlined through the use of an agreed-upon communication model.
We use the B-STAR process here, so every nurse uses that process when they're giving report from one nurse to the other. They talk about the background, the situation, the transition of the patient, the assessment, and the recommendations for the patient's plan of care.
In communicating with patients, the process starts early and occurs frequently.
We try to forge an early relationship with the patient and their families. We've had the hospitalist physicians here all have a photo card that we've made up that gives us a little bit of information about ourselves, our name, and our picture. And we also put a white dry erase board in each patient's room so that on a daily basis and throughout the day, we update it with information that the patient and the family might want or need. What the barriers to discharge are, results of diagnostic testing, because these are the things that the patients and the families want to know.
And lastly, the hospital is continually listening to staff and making changes if needed.
If someone brings up an issue that they feel needs to be addressed, then we address it and we follow back with them as to how we addressed it. And then if it doesn't work, we change it again. But everyone is very open and willing to listen to whatever anybody has to offer, and we found that through this process we are here today because of that.
This program has focused on ways to communicate more effectively, both between care providers and with patients during transitions of care. As we close, think about the following questions to help you formulate your next steps for improving communication. Beyond those already involved, what other professionals would it be helpful to involve in communications about your discharge process? How do you identify the need for translators, and how are they involved in the discharge process? What are your capabilities for electronic communication? And does your organization's electronic health record communicate with the EHRs of primary care providers and vice versa? You know, in the final analysis, communication is one of those things that would seem to be so easy to do well. But in reality, the process is more complicated than that. Effective communication takes work and perseverance. The effort is well worth it, however, to help your patients navigate through what can sometimes be a confusing system and ultimately find their way back home.